Hi, everyone. I'm Ravi Salgia, and welcome to very distinguished panelists who are going to be talking about lung cancer post-ASCO. And thank you so much, Dalen, for introducing us. And at the same time, what I'd like to do is to have everyone introduce themselves. So I'm Ravi Salgia. I'm a medical thoracic oncologist, and I'm the chair of medical oncology at the City of Hope. Shayma.
Thank you, Ravi, and welcome everyone. Hopefully this will be a great, fun evening with a great group of people that I'd love to talk to. I am Shayma Kazmi, and I am also a thoracic medical oncologist currently at Cancer Treatment Centers of America in Philadelphia, soon to be at the Penn Cancer Center in New Jersey in Cherry Hill. So thank you.
Erin.
Hello, everybody. Welcome. So pleased to be here with you tonight. I'm Erin Gillaspie. I'm a thoracic surgeon specialized in thoracic oncology down at Vanderbilt University Medical Center in Nashville, Tennessee.
Kim.
Hi, everyone, and I'm so excited to be here with you tonight and chat about lung cancer. I'm Kimberley Mack. I'm a radiation oncologist at Boston Medical Center, specializing in lung cancer.
And Hoss.
Hello, everyone. Thank you for joining us. I'm Hoss Borghaei, thoracic medical oncology at Fox Chase Cancer Center in Philadelphia.
Thank you. And definitely looking forward to a great discussion today. And everyone, please make sure you can just write your questions out and we will get to them as soon as we can. So Shayma has been selected to go first, and she has actually a presentation that she'll talk about.
So yes, thank you so much for giving me that opportunity. I'm going to get right into it. One of the abstracts that I really enjoyed at ASCO this year was the Amivantamab in combination with lazertinib for the treatment of osimertinib relapsed chemo-naive EGFR mutant non-small cell lung cancer. So that's a mouthful, and I'm going to try to unpack it a little bit for everyone who's attending. Just from a context standpoint, Amivantamab, or Rybrevant, which is the brand name, is a fully human bispecific antibody that targets EGFR and MET, and the FC portion has this immune cell-directed activity and has clinical activity across diverse EGFR mutant non-small cell lung cancers. In fact, just recently in May, got approval for exon 20 insertion mutation. In fact, it's the first drug to be approved in that setting. So that's exciting. Now, lazertinib is a potent third-generation TKI with efficacy in activating EGFR mutations, also T790M, and has CNS penetration. So putting these two together, of course, it's exciting. It has the potential of being very, work and synergistic, but also hopefully they don't have a ton of overlapping adverse events. So this was what was picked. So just from a standpoint of this particular abstract, it was funded by Janssen. This is part of the Chrysalis study, the phase 1 combination cohort design. So they designed it, of course, with the understanding is the phase 1, phase 2 study was looking at the dosing, and they settled on 240 milligrams for the lazertinib. With the amivantamab dosing, it was weekly in the first cycle, and then every 2 weeks starting the second cycle, and that is an infusion. Just from a practicality standpoint, that's something to keep in mind. Now, they included patients with metastatic unresectable non-small cell lung cancers, and they had to have an EGFR exon 19 deletion mutation or L858R mutation, and of course they needed to have measurable disease. Now, all of these patients needed to have relapsed from osimertinib, but they could not have had chemotherapy in the metastatic setting. I believe they allowed adjuvant chemotherapy. And then, so they also did this biomarker analysis because, of course, that's important for us to figure out which specific resistance mutations respond to which specific drugs. And then that's where the future is going. And they did not have, for patients that didn't have tissue, they had ctDNA. So they had a mixture of the two. And so let's talk about that. We had a total of 45 patients who had relapsed on osimertinib. 36% had an objective response rate. So that's one patient with a complete response with a CR who had progressed on OC, and 15 patients with a PR. follow-up of 8.2 months, 44% of patients remained on treatment. So that's 20 patients, and 69% had ongoing response. And the median duration of response was not reached. So we have a really respectful objective response rate in these patients, as well as a durability signal that looks great. Median PFS was 4.9 months. Now, when you really look at, and the question I had is, which of these patients really responded, right? What's the biomarker testing? The abstract isn't completely clear, and I'm going to look forward to more detailed information. It looks like there were 17 patients who had biomarkers present, and of those 47%, which is 8 patients, responded. Now, of the remaining 28 patients, 18 of them had unknown osimertinib resistance mechanisms. Of those, 8 responded. So now I don't know what these unknown osimertinib resistance mechanisms are. They weren't really spelled out. But of the 10 patients in that 28 that had the non-EGFR MET mechanisms of resistance, 0 response rates. So I think that's going to be the group of patients we'll have to be mindful of and really be careful with. These patients who don't have an EGFR MET related resistance mechanisms, and it makes sense, of course, right? When you look at the osimertinib resistance population, you're going to have EGFR related loss of T790M and other activated mutation, about half the patients, C797S mutations. And then you have maybe 5% of patients with this MET amplification, but then you have a whole host of other potential mutations, HER2 amplifications, FGFR1, KRAS, PIK3CA, small cell transformation, of course, which is devastating. So I think it's important to keep in mind that this combination was very, responsive in the patients who had EGFR specific resistance as well as MET. The median PFS for patients who were biomarker positive was 6.7 months, and the total median PFS of all the patients was 4.1 months. Now, when they checked the 20 patients who had adequate tissue available for IHC testing for EGFR and MET, the patients who had this 8 score that was very high, more than 400, had a 90% response rate. And the patients who had a low IHC score, again, highlighting that this is a combination most effective for patients who have an EGFR and MET-driven resistance mechanism. So what's exciting for me after this study, and of course, this is a great drug, is the phase 3 Mariposa study, which is now going to answer the bigger question of, is this combination going to in some way replace osimertinib frontline, right? So this is a phase 3 study. Arm A is going to be the combination of amivantamab and lazertinib. Arm B is OC, and Arm C is lazertinib as single agent. Much excitement in the future of the EGFR world. OC is absolutely not the end of the story, and really exciting. So I will pause there. I don't know if that took a lot of time, but I'd be more than happy to answer any questions.
So Shayma, thank you. That was a great presentation. So how do you see this going forward? Let's say the Arm A becomes very relevant and the PFS has been achieved. So is that going to be the standard of care, and how long do you give the IV drug, the amivantamab?
So those are obviously the questions we're going to have. I think the utility of osimertinib being oral drug once a day is not to be in any way, diminished with a weekly or bi-weekly infusion along with an oral agent. Though the safety profile of amivantamab lazertinib was very much what we expect. It wasn't horribly toxic in the sense of the EGFR related diarrhea and skin rash was manageable. Though most patients had it. It was mostly grade 1 and 2. And the MET related, the edema and other hypoalbuminemia wasn't too bad either. So I think that question remains to be seen. I think OC has firmly established itself in this place with really great data, and it's going to take a lot. PFS alone isn't going to replace it by any means, especially when the competing drugs are going to be more difficult to administer.
And as you think about the future in early stage disease, and certainly we'll talk about that from the surgical perspective in a minute,
Yeah.
is there a role for these drugs in early stage disease as well?
I think that would be much, much more in the future. I think we're still looking for the ADAURA OS data, right? So it's going to take some time for us to fully implement and embrace OC even in early stage disease, though I think most of us would say absolutely, but for stage 2-3 patients, that's a no-brainer. But the phase 1 patient, so I think it's going to take time for even OC to firmly establish itself there. And then absolutely, I think it's going to be a risk benefit in terms of evaluating. This is a first bispecific antibody. We don't truly know how it's going to affect patients long term. So I think people are going to need the long-term data.
And then as you think about, let's say this kind of regimen does become standard of practice, what can be the patterns of failure that one should think about?
I think it's really, really important as we do less tissue biopsies and rely more on the ctDNA that this small cell transformation entity is real. And I think we really need to make sure that in the right clinical setting with rapid progression of disease that we don't sort of skip over that histology, that tissue biopsy, because you can still maintain an EGFR mutation and still have a small cell transformation. So I think that's a message to be sent out. And then really doing these sequential liquid biopsies and making sure insurances cover these is going to be super important at times of relapse and progression. This is now becoming the long game, and we really need to sort of stratify and plan out as each mutation takes over and identifying which one of these might be the driver. So I think that that's going to be really important in this disease, as with some of the other, molecularly targeted diseases, as in lung cancer especially.
And what could be our strategies? Obviously, we'll talk about immunotherapy in a few minutes too, and we are seeing long-term survivors and really cures, quote unquote, right? But we don't see them with these TKIs. So what could be a strategy for us? And that's a very tough hypothetical question.
Right. So, I mean, we know that IOs in general as single agents perform poorly in patients with EGFR and ALK-driven non-small cell lung cancers and may potentially have more down the line immune-related AEs because of the potential interaction with the TKI. So we have, of course, moved away from that completely. However, the Empower 150 trial showed us that perhaps the combination of platinum-based chemotherapy along with an IO, along with Bev, now that was a quadruplet, right? And that might be financially toxic. And there may be patients who may not be able to handle the quadruplet, but there is definitely the room there that was explored of IO along with chemotherapy in patients who have progressed on targeted drugs. Now, if we come up with more and more sequential targeted drugs, then I think that's going to get pushed off further down, because I believe that if there is a specific targeted drug available for a patient, that would be always my first choice over chemo or chemo IO. So I think that if there is a fourth generation TKI and then a fifth generation TKI, that's where I think we're headed.
Great, thank you. Thank you, Shayma. And certainly we'll come back to you and all the panelists as well together. And it's my pleasure to have Erin talk about the surgery.
Thanks so much. So I'm actually going to kick off talking about Violet, but actually giving a little bit of historical context to why this study is really important and why it's taken so long to find out really definitively Vats versus OPIM. And so, the 1990s were really when we ushered in this new evolution of minimally invasive surgery with the advent of laparoscopy and video-assisted thoracoscopic surgery, or VATS. And really over the course of the next 10 to 15 years, we see advancements in equipment, so them becoming a more specialized experience for surgeons grew. But broad uptake of VATS was really slow as many surgeons awaited data confirming safety and efficacy. So during the early aughts, many single centers with high volume began publishing results, demonstrating that VATS could be performed safely and economically. One of the big ones was in 2006, Dr. McKenna published his experience with 1,100 cases, and he found that lobectomy with an anatomic dissection could be performed with low morbidity, a low risk of conversion to thoracotomy, early discharge, and low mortality rates. And importantly, the risk of intraoperative bleeding was minimal. So this addressed a critical concern and fear at the time for surgeons performing this procedure. Beyond safety, we start to see reports coming out saying we have other benefits such as reduced pain, decreased duration of the chest tube, shorter hospitalizations, and decreased recovery time with a concomitant improvement in quality of life. Some even started to note that perioperative risks and complications were fewer. But really, we still don't see a big number of surgeons doing VATS. And there was a lot of questions about ability to translate these single center results across all centers. And by 2012, still only 30% of lobectomies were being performed with a minimally invasive approach. A driver of this really poor uptake was the concern about oncologic safety of the procedure. And an editorial published by Dr. Matthiesen cited some of the significant oncologic concerns. So one of them was really just how the surgery was being done. So a new fissureless approach, which could compromise and reduce the number of lymph nodes being resected from the fissure. Another was a concern about the ability to actually remove station 7 or subcarinal lymph nodes. He cited a study by Licht and colleagues who actually compellingly argued that upstaging occurred far less in the VATS cohort of patients compared with open, suggesting an insufficient nodal dissection and a missed opportunity for adjuvant treatments. So at that time, Dr. Matthiesen called for a randomized prospective trial comparing VATS with open lobectomy for early stage lung cancers. But unfortunately, we really didn't see that for some time. Proxy studies emerged attempting to compare the modalities. So we see Dr. Berry and colleagues publishing retrospective outcomes, single institutional looking at VATS versus thoracotomy. In their hands, in 560 propensity matched patients, they found that operative approach actually did not impact survival at all. Similarly, NCDB database analyses comparing VATS and open lobectomy for stage 1 confirmed all of the benefits that we were already seeing. So shorter length of stay, mortality in the perioperative period was absolutely appropriate. And again, no compromise to nodal evaluations or reduction in long-term survival. So we have a big call for broader implementation of minimally invasive techniques. But the commonality to all these studies is that they're retrospective, they're single institution, or they're database studies, which we all know are really difficult to answer questions, especially when the database is not designed with these specific questions in mind. So really, it has taken approximately 30 years for us to get the large multi-institutional trial that Dr. Matthiesen has called for, and that is Violet. And so it was a multi-institutional prospective randomized trial conducted in 9 centers around the United Kingdom. It was led by Dr. Lim, and he and colleagues set out to definitively compare outcomes in VATS and open lobectomy for early stage lung cancer. The inclusion criteria for the trial were patients with known or suspected clinical stage T1 to T3, N0 or N1, and M0 lung cancer. They enrolled patients between July of 2015 and February of 2019. They actually accrued a total of 503 patients, of whom 247 were randomized to VATS and 256 were randomized to open. All of the centers that were included were centers that specialized in lung cancer. They had to have a certain minimum number of cases per year and a certain minimum experience with VATS. The early data was actually first shared in 2019 at the World Lung Meeting in Barcelona, and the 1-year results were shared in this abstract at ASCO. The perioperative outcomes were broken down into a few different categories, and the first was patient experience, which is so important when we're thinking about surgery. And the study revealed that patients undergoing a VATS approach had less perioperative pain, lower analgesic consumption overall, and interestingly, when they looked at the reduction in pain, they actually found that this persisted up to 1 year. So patients had less early pain and less chronic pain. Patients undergoing VATS also had a better functional recovery. And so they defined that as better physical function at 5 weeks post-surgery when they were being seen in follow-up. Vats patients also scored higher overall and improvement in their global health status. The team then evaluated perioperative morbidity. The Vats arm had fewer overall complications and no significant difference in serious adverse events. The median hospital stay was shorter in the Vats cohort, a difference of 4 versus 5 days, so not a major difference, but it is a day. Post-discharge, the Vats cohort had fewer serious adverse events, as well as a lower readmission rate. And again, this persisted up to 1 year, 29% versus 35% in the Vats versus open cohorts, respectively. Interestingly, they also noted that of the patients who had positive nodal disease identified at the time of surgery, a greater percentage in the Vats arm went on to receive adjuvant therapy. So 51% versus 46% in the Vats versus open arms. So we're seeing a slightly higher percentage of patients who are going on to that adjuvant therapy. There was no difference in time in initiation of the adjuvant therapy. So both were able to get to it in a timely fashion, but a greater percentage of the Vats patients. Patients were also monitored for recurrence, both with clinical follow-up and CT scans. Results at 1 year were similar for recurrence between the Vats and open arms at 7.7 and 8.1% respectively. Progression-free survival and overall survival were likewise not significantly different. So Dr. Lim and colleagues concluded that Vats lobectomy for lung cancer is associated with less pain, fewer in-hospital complications, a shorter length of stay, which was achieved without compromising early oncologic outcomes, nor an increase in severe adverse events. And so this, coupled with fewer readmissions and a superior functional recovery, really looks very favorable, favoring the Vats approach for patients. So I think very promising early 1 year data, and I'm really excited to see if this continues, these outcomes persist at the 2 year, 3 year, and 5 year mark. So again, really, really thrilling study for us. And as I think about the results of this study and my own practice, I perform predominantly minimally invasive surgery. And so very gratifying to see that we're doing this safely, effectively, and in an oncologically safe way. I think one of the biggest underlying lessons is that Vats should be thought of as a tool in our surgical armamentarium. And just like any surgical tool or treatment, if it's misapplied, the patient's at risk for a poor outcome, both with regards to the perioperative risk and long-term oncologic outcomes. And I think this is really well highlighted in the data that we keep seeing talking about the nodal resections. So, in this study, they had a minimum number of lymph node stations that had to be resected and a minimum number of nodes that had to be resected. And so these surgeons were doing a very effective Vats approach, doing a thorough lymphadenectomy just as they would via open approach. And so I think it's really incumbent upon us as an oncologic community, as a surgical community, to ensure that we're standardizing the definition of what is a quality lobectomy to assure that we're giving patients really high quality surgery, high quality oncologic outcomes.
Great, thank you, Erin. So in your practice, do you only do Vats, or when would you consider an open lobectomy?
Yes, that's such a great question. So probably 90% of the cases that I do are either a Vats or a robotic approach, but a lot of it depends on the size, the location of the tumor, patient's functional status, what we think they'll be able to tolerate. So a Pancoast tumor, for example, especially if it's invading multiple ribs, close to the brachial plexus, those generally I'm going to be doing, potentially a combined Vats and open approach to try and minimize the total degree of incision that I'm performing, but, being able to very carefully dissect off the brachial plexus, if I have to do reconstruction of a vein or artery, those are I'm going to be doing in an open approach. Likewise, sometimes after neoadjuvant or induction treatment, or sometimes in cases where I'm going after patients that have single site residual disease, sometimes I see a significant amount of scarring in the hilum. And so it can be a little bit more challenging to control the proximal vasculature. And what we never want to do when we're doing surgery is we never want to compromise oncology or oncologic outcome or safety in favor of smaller incisions. And so, when I'm encountering a significant amount of hilar scarring, definitely thinking about doing an open approach in those patients.
And as you think about all of us in the multidisciplinary fashion are seeing more and more older patients. So in these studies, you don't include that many older patients. So is there a bias in the older patient population to automatically go to Vats or robotics instead of open lobectomy?
Yeah, I think that's such an important question. And I think when we're applying the results of studies, it's so important to know what patients were actually included in those studies in making kind of broad, generalized application and approaches. You know, the thing that I always try to shy away from is strictly looking at an age. I think it's really important to fully assess the patient's functional status. You know, not all 80-year-olds are created equally, not all 60-year-olds are created equally. And so creating a really thoughtful plan, you know, incorporating not only our pulmonary function testing, looking at our comorbid conditions, functional status, using those, you know, free assessments. I walk my patients around clinic, watching them get up from the chair and get up onto the table. I mean, that is such a rich way to make assessments about patients and what they can do, and then creating a treatment plan that kind of fits them. I think the other thing that kind of always makes me worry just a little bit is sometimes people do a lesser resection because of a person's age. And so they say, oh, well, I'm just going to do a wedge in this person because they're this age. But if you have an 82-year-old that is in perfect health with no other comorbid conditions, perfect pulmonary function, walking, you know, an hour a day, you know, giving them the best oncologic surgery that we can, I think is really important. And so thinking about doing a lobectomy with a good lymphadenectomy in that patient, you know, and thinking about multidisciplinary approach, presenting them a tumor board, making sure we're doing the right surgery for them, for their physiologic condition, I think is of paramount importance.
You know, many cooperative groups had tried a number of trials in terms of surgery, let's say lobectomy versus wedge and other randomized types of studies. And it's been taking a long time, like you said, 30 years, and UK was able to do that. But how do you implement this worldwide? Is there a momentum from the Thoracic Surgical Society to do this?
Yeah, there is. And I think, you know, there was a few kind of hiccups along the way that led to slow uptake. You know, one was the lack of availability of specialized equipment. We have that now. We have, you know, specialized Vats equipment that's specifically designed to work within the chest. We have better cameras. We have better screens to make the surgery a lot safer. There are still some quirky limitations to how we do surgery, though. And a lot of people don't really think about this if they're not performing the surgeries. But when I do Vats surgery, I am operating on a 2-dimensional screen. So I have no depth perception. So I'm operating on 3-dimensional delicate structures in 2 dimensions. And so there are some people who really struggle to be able to interpret that 3rd dimension in their mind as they're dissecting around things. Robotic surgery overcomes that limitation. And so we now have 3-dimensional viewers, but we have no haptic feedback. So what do I mean by that? That means I can't feel how hard I'm pulling on things. So if you put your hand on something, close your eyes because you couldn't do this with your eyes open, and pull as hard as you can, the robot's going to let you pull hard on whatever structure it is that you're around. Now, I swear to you, having operated with a robot for a number of years now, I totally have haptic feedback, but what it is my brain looking at all these structures, looking at the tissue tension and giving me feedback and saying, this is how hard you're pulling on something. But there's no haptic feedback. So for some surgeons, that's a huge, huge, huge leap. And then of course, there's a challenge with bleeding. So a lot of people get very nervous. You know, are you going to be able to control bleeding effectively if you get a PA injury or bad vein injury, minimally invasively? And I think that's where you have to have teams that train together, practice emergency drills, and have a clear plan of this is how we're going to control this if this happens. Because if you operate long enough, you're going to get into bleeding at some point. And you have to know how you're going to be able to handle it to keep the patient safe.
So you're prepared to do a VATS, but then go to an open surgery if you need to.
Absolutely. Absolutely.
Mm-hmm. Great, Erin. Thank you. And we'll come back to panel discussion again. Absolutely. Kim?
So hi, everyone again. And as the radiation oncologist on the panel, I'm delighted to have the honor to discuss an important trial in small cell lung cancer, specifically limited stage. So this is CALGB, and it was an alliance trial, so 30610, R2G0538. And basically, this study was the largest small cell lung cancer study to date, for radiation at least. And you know, the background on this particular trial is that while the chemo, platinum-based with etoposide has been the backbone for small cell lung cancer for years, the radiation dose question has actually been sort of answered, but not. And why I say that is because Intergroup 0096, which was published in the New England Journal in 1999, so over 20 years ago, set the standard, right, for 45 gray twice daily. But that study compared, the comparison there was to a daily arm of 45 gray only. So 45 gray twice a day compared to 45 gray once a day. Most radiation oncologists don't think of that as biologically equivalent. One was essentially a lower dose. And then the other concern was, back then at least, there was a significant toxicity with the 45 gray BID arm. And in particular, the esophagitis rate, grade 3, was over 30%. So fast forward in the intervening years, we've looked at various doses in smaller studies. So CALGB had a pilot that was 70 gray in 2 gray fractions, which ended up being the comparative arm in this phase 3 study. And then there was also an RTOG pilot, 0236, that looked at 61.2 gray in 34 fractions, given initially daily and then twice daily at the end. And that was actually the third arm on this trial that was presented at ASCO this year, but was dropped in the interim analysis. The other study that I should mention sort of as background is CONVERT, which was performed in the United Kingdom, and that looked at 66 gray daily compared to 45 gray twice a day. So again, that's our sort of historical backbone, the standard of care. And that showed no difference in overall survival or progression-free survival. And that trial was actually started at the same time as this one, but completed 5 years later, so from 2008 to 2013. This trial took actually 11 years to accrue. So that's one thing to be mindful of, is that these trials often are difficult to accrue, and there were several major amendments that were required in order to finally bring it to fruition. But hats off to the investigators for getting it done and reporting this important study. So just a little more information in terms of the chemotherapy for our medical oncology colleagues here. Cisplatin was 80 milligrams per meter squared on day 1. Etoposide was 100 milligrams per meter squared on days 1 to 3, every 21 days for 4 cycles. So very standard in that regard. And at the beginning of the trial, radiation had to start during that first cycle, and carboplatin wasn't allowed. One of the major amendments was that carboplatin subsequently was added to the armamentarium of acceptable chemotherapy regimens. So in total, there were 638 patients, as I noted before, the largest trial in small cell. Stratification was by gender, weight loss, performance status, and radiation technique. So that's an important point for us radiation oncologists in this current year, 2021. We have IMRT available to us now, and we use it frequently in lung cancer. Back when Intergroup 0096 was published in 1999, IMRT wasn't routinely used. So that allows us to potentially better sculpt dose around critical structures, including the heart, the esophagus, the spinal cord, and even depending on the anatomy of the tumor, protect the lung better as well. So the primary objective of this study was to see if the experimental arm, which is daily 70 gray in 35 fractions, was that superior to the standard arm of 45 gray twice a day. And the specific endpoints were median survival as well as 2-year overall survival. So, as I noted, there were a couple amendments that were required, but eventually they managed to accrue the number of patients they needed, especially after they dropped the 61.2 gray arm. The toxicity was worse on interim analysis. The arms were well balanced when we look at the 2 groups that were in the final analysis. And a couple of things just to note, IMRT was used in about 60% of the cases, so that's the majority. So it really looks like it was modern radiation techniques given. Only about 40% of the patients received their chemotherapy and radiation on the same day to start. So most required, a little bit more time for radiation to be planned. That's pretty standard from my practice as well. We want to get the chemotherapy started as soon as possible. And usually in order to get an excellent radiation plan that, dose escalates into the tumor while protecting all the normal structures, that can take us, maybe an extra week or so before we can start the radiation with the chemotherapy. And then only about 18% of the patients received carboplatin, but that did obviously help with accrual. So the results, right? So we're looking for an improvement in survival with the daily radiation dose escalated to 70 gray. We did not see that. So the median survival was 30.5 months for the daily arm, 28.5 months for the twice daily standard arm, not statistically significant. And the 5-year overall survival was 34% for the daily arm compared to 29% for the twice daily arm, but again, not statistically significant. Progression-free survival were basically essentially the same for median 2-year and 5-year survival endpoints. Now, something important to note in this trial, and we actually saw something similar with the non-small cell dose escalation study, RTOG0617, that compared 74 gray to 60 gray daily, is that there were more deaths in the high dose arm. So 11 deaths in the 70 gray daily arm compared to 4 deaths in the 45 gray twice daily arm. It'll be interesting to look at the final publication and characterize these grade 5 events more carefully. But at least in the abstract that Dr. Borghaei presented, it looked like they attributed 5 of the 11 to possibly being due to treatment compared to 2 of the 4. So about half for each. But still that leaves, 6 deaths that were unrelated, at least by their initial analysis, with the daily arm compared to only 2 in the twice daily arm. So, whether that can account for some of the null effect in survival, that it's possible, there's over 600 patients in the study, so 11 deaths versus 4, probably not. But certainly something to be carefully investigated. We're still learning from RTOG0617, the non-small cell, equivalent, if you want to call it that, in terms of dose escalation daily. And what we're seeing is that heart dose is really important, and we don't quite have a handle yet on how to fully account for that, in part because the tumors vary in location, right? They can be right next to the heart. They can be a pancreas tumor, light years away from the heart. And that will really impact our ability to really say, is this too dangerous for us to treat or not? And we can't avoid the heart in most cases, right? So I think that'll be something very interesting to look at in the final publication of this study. Then the other toxicity I'd mentioned earlier was esophagitis. So even though it was over 30-something% in intergroup 0096, 32%, it was only 17% in this study. So again, 45 gray BID. The big difference then is radiation technique and perhaps knowledge of how to sculpt dose around the esophagus better. So, that was really encouraging to see for 45 gray BID, that, one of the things we were most concerned about back then, at least, was toxicity, and we're not seeing that different now comparing daily to BID. And, just to summarize, there weren't many major toxicity differences between the two arms. So, what do we walk away with here, right? It's a negative trial, but it's a big trial, and it's an important one to date. And I think in the absence of a non-inferiority study, this is the best answer so far we have, that we can do daily radiation or twice daily. And I'd be curious to hear about everyone on the panel's practice, because it varies by institution, but there were several studies back around the time the intergroup came out, so 20 years ago, that basically showed that there were only about 10% of patients being treated twice daily, and that didn't really change after intergroup was published. So it didn't really change radiation oncologists' practice patterns. And then I'm not sure if you guys use MedNet, but I checked out there's a survey on MedNet, and it's been going on since 2015, and it's still ongoing, so you can still click and answer. But I just checked it earlier today, and it looked like, again, still a vast minority of patients being treated by BID fractionation schemes. The majority, I think it looked like a 70% were treated with daily radiation schemes. So this study basically helps those who are sort of forced into offering their patients daily treatment, sort of a breath of relief that they're doing the right thing for me personally, you know, my hospital is a safety net hospital, and we found it very difficult to sort of enforce to patients that they had to come twice daily, 6 hours apart. Many were actually trying to get to work, and even coming once a day was challenging enough for them. Others, you know, with poor performance status relied on other services or your family members to give them a ride, and they just weren't able to come. So it's very rare that I find I have a healthy enough patient with a solid social background who can basically accept coming twice a day for radiation. So from my personal perspective, I often have to tell my patients that, you know, if you can't do twice a day, daily is from what we know, an acceptable alternative. And this study helps me say that more confidently, though in the end, it's a non-inferiority study that will actually be able to allow us to fully confidently say that. So this is with a grain of salt that this is a negative superiority trial, right? Not a non-inferiority trial. So I look forward to seeing the final publication and looking at quality of life data, adverse event data in more detail, try to figure out why there were more deaths in the high dose arm. And then the last thing I'll just comment on is that this study was 70 gray and the convert study was 66 gray. So there's also quite a bit of discrepancy and variation amongst radiation oncologists, whether to go anywhere from 60 to 70 gray. My personal preference is I usually go right in the middle at 66, but if dose metrics aren't being met, I'm worried about the heart dose, for instance, or the brachial plexus dose. We certainly don't have convincing enough data that we can cause inferior outcomes by going to 60 gray. So it's a question of balance between local control and toxicity in the end, right? So hopefully I have given a good summary of this trial and look forward to any questions that anyone might have. Thank you.
Thank you, Kim. So as you think about, you're exactly right, BID versus Q-day radiation, and it is challenging to have it as twice a day. And you know, where do patients hang out if they want to hang out in the lobby, and especially in this COVID era, right? It's a very challenging situation for all of us. But did it surprise you with this result? So for example, for non-small cell lung cancer, when we saw that data, that was surprising and in terms of the high dose. How about for the small cell? Did that surprise you at all, this data?
I'm not surprised it's a negative study because I think to show superiority, we really would have had to know that the 45 gray BID arm was not what we expect it to be, right? But it's been the standard of care for so many years, and we've seen people cured of it, many people, right? Well, a small proportion, but many overall, right? So I think, you know, it did look like from the pilot data that we could potentially see a difference, but in the end, I'm not surprised personally that you know, it's a null study. Just again, because you really have to have quite a marked difference and a marked detriment for 45 gray BID and a marked improvement from the 70 gray daily. And I think with the balance of toxicity and the fact that if you're radiating 70 gray, that means your lung dose, your heart dose, you know, those are the big two that potentially impact survival directly, potentially esophageal toxicity too, though. And so you get that balance of increase in potential local control, but an increase in toxicity with it. And so what does that translate to in terms of survival, right? So I'm not surprised, but I think it was a valiant effort by the investigators for sure. We needed to see this, right, to really know.
And in terms of the toxicity, do you think for small cell, majority of our patients are smokers or former smokers? And do you think that plays a large role in this?
I think so. You know, certainly when I have an active smoker on treatment, they seem to do poorly, more poorly than the folks who at least quit smoking many years ago. You know, and obviously a lot of other confounders are there, right? The heart disease and, you know, pulmonary function, right? Those are all intertied with smoking status typically. But yeah, I think certainly, you know, we're not working with the patient population that is healthy at baseline. And so that increases the chance that our radiation causes toxicity. And then it's really hard to tease everything out, right? You know, the number of covariates in your multivariate model just increases exponentially. And then you don't even have a way to assess, you know, potentially all of those confounders, right?
And then, you know, we have not moved the needle for limited disease small cell, period. How do you think we can do that as you think about the future?
Yeah, that's a great question. You know, I think our radiation dose is really stuck, right, with this balance of toxicity versus, you know, needing to cause tumoricidal doses. So, you know, is there a role for immunotherapy, right? Is there a role for improving the systemic aspect? We think of small cell as a systemic disease anyway. You know, I think that's going to be an important way that we can potentially move the needle forward with, you know, using what radiation dose we have. You know, our radiation techniques are getting better and have gotten better, but I'm not sure if they alone can really drive the improvement in this disease, just because its prognosis is so poor overall.
Great, thank you, Kim. And we'll definitely come back to a group discussion in a few, and would love to hear from Hoss now.
Thank you, Dr. Salgia. This is my task is to talk to you guys about the Checkmate 9LA regimen. You can hear me, correct? Because I'm getting an indication that, okay, good. All right. So we want to talk about Checkmate 9LA. It goes without saying that in patients with metastatic lung cancer, I mean, the treatment landscape is completely different than what we had, you know, just even 10 years ago. In addition to all the molecularly driven tumors for whom we now have quite effective targeted therapies, and 7 or 8 FDA approved regimen, more to come, moving things into the front line a little bit more. The introduction of checkpoint inhibitors has been a great sea change for us here. We all have seen long-term survival data with checkpoint inhibitors. They started in the second line space. Some of those papers have already been published discussing 5-year overall survival advantage. We've had frontline studies showing significant survival advantage. But the bottom line is that what we are observing now is that only a minority of our patients are really benefiting from checkpoint inhibitors, and that's good. I'm not complaining about that. I'm just suggesting that there's a lot of room for improvement. So the work that we have started and the momentum that we have gained with all of the positive studies in the metastatic non-small cell lung cancer is something to build on. And I'm hoping that we don't lose that momentum and we continue to make improvements in the outcome that we have been observing. So the frontline treatment of patients with metastatic non-small cell lung cancer without molecular alterations, it's been dominated by a couple of studies. Patients with PD-L1 over 50% based on Keynote-024 have been enjoying a relatively simple treatment with a tolerable toxicity or manageable toxicity, I should say, with a really good clinical outcome, including long-term survival data that we've seen. For patients with lower levels of PD-L1 expression, studies such as Keynote-189 have indicated that a combination of chemotherapy with a checkpoint inhibitor can be quite effective in achieving high response rate, improvement in PFS, and overall survival. We also have single agent data from EMPOWER studies using the atezolizumab, again indicating that in select patients populations with high PD-L1 expression, single checkpoint inhibitor use can be quite effective. So chemotherapy plus immunotherapy has become a favored regimen for many practicing oncologists because of the really good clinical efficacy data that we've observed. Some of our colleagues are actually offering chemo plus immunotherapy to patients with metastatic disease, regardless of PD-L1 expression. Chemotherapy has been around for quite some time. Cytotoxic side effects from treatment is clear to all of us, and we're not going to go into it. But exploring potential alternatives is also something that has been looked into and explored. And one example was the combination of ipilimumab plus nivolumab that was extensively studied in a phase 1 and then a phase 2, and then eventually in Checkmate 227. I have said this several times, and I am going to continue to say it just so that we are completely transparent, and you all know where our biases lie. And my bias has always been towards an IO regimen. I've always thought that made a little bit more sense than using checkpoint inhibitors with chemotherapy. Nonetheless, I have to admit that you cannot deny the great clinical efficacy that we've seen with chemo plus checkpoint inhibitors. So 227, combination of ipi-nivo with low dose ipi, as we call it, 1 milligram per kilogram, continued every 6 weeks, was able to show clinical efficacy as compared to chemo alone or chemo plus nivo in Checkmate 227 in patients with PD-L1 positive tumors. And because of the statistical design of the study, ipi-nivo alone at this point is FDA approved for PD-L1 over 1%. Clearly, because of the success of chemotherapy plus checkpoint inhibitor studies, it made sense to explore the potential activity of adding chemo to an ipi-nivo backbone, and that's what was accomplished in Checkmate 9LA. The dose of nivolumab was a little bit different in 9LA compared to 227, but the dose of ipi remained the same. And the decision was made to use an abbreviated course of platinum doublet chemo with ipi-nivo as part of Checkmate 9LA. And there are many reasons and rationalizations as to why we should use an abbreviated course, and we can discuss that. I think one of the biggest criticisms of 9LA is that the comparator arm was chemotherapy alone and not chemo plus immunotherapy. And again, historically, when the study was being designed, many of the chemo IO studies were still pending. We might have had some phase 2 study results. Nonetheless, that remains an issue because, again, we're comparing chemotherapy to a combination like 9LA, where you basically are using 4 separate drugs. This was a nicely designed study, a lot simpler than 227, only 2 arms, about 350, 360 patients per arm. And the control arm, again, was platinum doublet histology based, and the experimental arm was epi and nivo combined with 2 cycles of histology-based chemotherapy. The study was first presented about a year ago, so at this year's ASCO, we actually had the 2-year updated overall survival data, indicating that in all randomized patients, the experimental arm, which is epi-nivo plus chemo, led to a median overall survival of around 15.8 months versus 11 months for chemo alone. The 2-year OS benefit was 38% with chemo plus ipi-nivo versus 26% in patients who received chemotherapy. Subgroup analysis was also kind of interesting, at least I found it interesting. One of the issues that has come up in some of the other IO studies also is that patients over the age of 75, and the numbers were small in the study, only 70, the hazard ratio was right around 1, but the confidence interval that obviously crossed because the number of patients who participated was low. But I have seen that in some of the other studies, and that has led to some hypotheses regarding patients over the age of 75 and the role of immunotherapy. It's not consistent, I have to admit. Nonetheless, it's been seen before. Also, the never smoker patient population in the study, there were about 98 of them that were basically randomized. And the hazard ratio there also is in favor of chemo, and again, the confidence interval is rather wide. But interestingly, regardless of the level of PD-L1 expression, so even PD-L1 negative tumors had clinical efficacy with the combination versus chemotherapy alone, and also patients with CNS metastases, and that was a decent number, about 120 patients, had a hazard ratio around 0.47 on this study, favoring the quadruple therapy as opposed to chemo alone. PFS and duration of response were also in favor of the combination versus chemotherapy. And again, the duration of response is something that we've seen in other immunotherapy-based regimens, especially Ipi-Nivo, indicating that patients who do have a response are able to maintain that for quite some time. Efficacy was then divided based on PD-L1 level of expression. PD-L1 negative tumors, I think the interesting thing that I'd like to bring out is the fact that in the squamous cell histology, the hazard ratio for OS in PD-L1 negative was about 0.48, which made it a little bit more interesting for me, and something that, again, I think could potentially be useful in a clinical setting. For the non-squamous histology, the hazard ratio was 0.75. For those over PD-L1, over 1%, again, the benefit was seen across the board in terms of OS, PFS, and duration of response. And again, interestingly, PD-L1 over 50% patient population were able to achieve a median overall survival of around 19 months versus about 13 months for the chemotherapy alone arm of that study. There's always a concern regarding the use of ipilimumab. We're all familiar with the potential adverse events associated with the use of CTLA-4 antibodies. And again, keep in mind that the dosing and schedule of delivery of Ipi along with Nivo came as a result of a fairly extensive phase 1 and 2 evaluation. But nonetheless, yes, the combination does have toxicities that I think we all have to pay attention to. Almost everybody who participated in the trial had some level of toxicity, but first of all, treatment-related deaths were fortunately low in both arms of the study, and two. But adverse events leading to discontinuation of all of the component of the regimen. To those who were grades 3 and 4, leading to discontinuation of the whole treatment, about 14% in the Ipi-Nivo plus chemo arm versus just about 3% in the chemotherapy arm of the study. And again, I'm not trying to minimize any of this, but these are toxicities that we're all familiar with, immune-related adverse events, and definitely requires extensive monitoring and proper management and identification of these adverse events, timely, I should say, identification of these adverse events. Another analysis that was done was the grade 3 and 4 adverse events seemed to happen at a higher rate early on in the course of the treatment, and as the number of cycles continued, there was a reduction. Again, it's never zero, but it was a reduction in the number of adverse events going from cycle to cycle. And in a completely exploratory analysis, those patients who actually discontinued Ipi-Nivo chemo due to treatment-related adverse events actually had a better clinical efficacy when you compare them to the all randomized patients. And I know that Dr. Shoshinsky presented data from a pooled analysis. And I think that's another interesting sort of tidbit that's coming from a lot of these immunotherapy-based studies. We've seen single institution studies, again, suggesting that an adverse events that immune-related could in fact be a biomarker of clinical efficacy. And we'll see if we can come up with explanation for that. So putting it all together, this updated result from 9LA confirms the clinical efficacy of the combination with the longer follow-up. It indicates that the toxicities are not increasing with the longer follow-up of the patients. And there were subset analyses that are very, at least hypothesis generating in my view, and interesting, and it offers our patients yet another potential treatment option when we are discussing treatment options with them in the clinic. Thank you.
Thank you, Hoss. So how are you doing this in your practice? You have Pembro or carbopemetrexate and Pembro, or a combination, the quadruplet regimen, as Shayma said, or you have now this checkmate 9LA or Nivo Ipi by itself. How are you deciding in your practice with your whole group?
Yes. So What we have decided, or at least the way I do it, if sort of algorithmically, in the absence of any contraindication, patient is a candidate for both chemotherapy, immunotherapy. My options are high PD-L1 expression, single agent checkpoint inhibitor. I'm very sold on that idea. The higher the level of PD-L1 expression, the more comfortable I am with single agent IO. I have to preface this by saying, in the absence of clinical trial for participation, that's the way I would use it if it's standard of care. So high PD-L1, single agent checkpoint inhibitor, I'm very comfortable with it. PD-L1 negative tumors, my preference is an ipi-nivo regimen, but since that regimen is not FDA approved, and sometimes it's a little bit difficult, I do use a 9LA. Now I have to tell you, I actually like the 9LA because if you look at the PFS curves, with just 2 cycles of chemotherapy, we are able to avoid that rapid progression that we used to see in a lot of the IO-based studies. So the cytotoxic effects of the chemotherapy, I think, is actually rescuing some, you want to call it hyperprogression or just not enough time for the IO to kick in. So I actually like that component of 9LA because it gives me that additional oomph that I need for the immunotherapy to kick in. So for PD-L1 negative subgroup of patients, particularly the squamous cell histology, I favor the 9LA regimen. Again, we can get into the TMB discussion and all that too, but let's leave it at that. For everyone else in between, the 1 to 49%, again, in the absence of trials, my preference has been to use chemo plus IO because of the higher response rate that we observe in those studies in that patient population.
You talked a lot about PD-L1, but yet we're confused. Are you going to do 22C3 or the 28A or the SP142? Which one do you do, and which one do you want us to be able to do in our practice as we go forward?
So I'm actually surprised that still is a question, because we had 2 blueprint projects showing us that all of these antibodies are basically equal. There are minor variations, and that's fine. But if we learn anything from the blueprint projects, is that there really aren't major differences between what we measure with these antibodies. And I think it's very difficult for any academic center. I'm sure there are a few who would do it, and maybe Ravi, your institution is one, but it's difficult for us to have several different platforms. So we are sticking with the 22C3. The data is rather consistent. There's more data with it. And it has sort of been incorporated into our workflow, but I don't even bat an eye if I see someone in a second opinion who's had another PD-L1 test other than 22C3, because I think the data is matched very well with the 22C3. So I really don't have any issues with using a different antibody for PD-L1 measurement.
Great answer, because there are commercial vendors who are giving us 3 to 4 different antibody testing. And I'm positive that each one costs money, right? And so we have to really be cost effective, value-based medicine driven. Exactly right. What about side effects? And how, I mean, of course, that's opening up a whole Pandora's box right now, but how does one think about side effects? How do you approach that in your practice as you think about 9LA versus others? Yeah, and again, I'm being very honest with everybody. We have been involved with the 227 and ipi-nivo regimen for quite some time. In our institution, using the combination of ipi-nivo for other diseases, such as renal cell melanoma, lung cancer, has been commonplace. We have very good processes in place to identify patients who are at risk or when they call with a problem when they're on these regimens. And I gotta admit, I don't find the ipi-nivo regimen to be significantly worse in terms of toxicity than what we have been using. Now, do we get a little bit more grade 3 colitis with ipi? Absolutely, I'm not denying that. But it is not like I'm seeing 15% pneumonitis rate when I'm using an ipi-nivo regimen. Is chemo IO side effect more manageable? I think if you
think about it critically, because we are so used to managing cytotoxic chemotherapy side effects, we don't even think about them. Somebody's neutropenic, we add growth factor support, or we hold the treatment, or adjust the dose. Somebody has nausea, we add another antiemetic or adjust. So a lot of the other side effects that we typically associate with cytotoxic chemotherapy, we sort of subconsciously, I think, are sort of discounting and saying, oh, those are manageable and we just go with it. But whether I have a biased view of this or whether I've just been lucky, knock on wood, I haven't had significant issue with an ipi-nivo regimen. Again, have I been forced to discontinue somebody on ipi-nivo because of side effects? Absolutely. But I've also been forced to discontinue treatment in somebody with grade 4 pneumonitis on single agent IO with a PD-L1 of 80%, and it just happens to all of us. But the rate with ipi-nivo is definitely higher, and again, I'm not denying that, but it is not something that's a showstopper for me in the clinic in the appropriate context in an appropriate patient population.
And the last question before we open it up for group discussion is when you do see these kinds of side effects and you stop, do you re-challenge, or what are your criteria for re-challenging versus you'll never do it again?
I mean, clearly grade 4 toxicities, I will not re-challenge. Toxicities involving vital organs, as my colleague and our friend, Dr. Marty Edelman said, you can't go and buy a heart from someplace. So, you know, a cardiac toxicity, I will not re-challenge. I think there are certain limits to what we can do. A side effect that I can reverse with a short course of, you know, high-dose steroid taper without significant complications, with appropriate patient consent and information, I'm willing to re-challenge, understanding that I walk into the clinic and I tell the patient, before your side effect, the potential for pneumonitis and colitis was 4%, now it's 50%. Do we want to continue or not? Because we have data from other institutions suggesting once a side effect happens, that patient's risk of developing another immune-related adverse event is substantially higher. And I also think it depends on the clinical scenario in terms of how many options we have for subsequent therapy. Is a patient good candidate for trials and we can forego it, the checkpoint inhibitor that we were using? I think a lot of this comes into play when you want to make a decision regarding you know, somebody who had a grade 2 or 3 side effect and re-challenging them. So that's the way I usually approach the management of these adverse events and re-challenge questions.
Great. Thank you, Hoss, and thank you for everyone presenting such beautiful data. And we'll open it up for group discussion, more like a multidisciplinary type of a discussion, a tumor board type of a discussion. There were a number of questions for Erin, Shayma, and Kim. Do you want to ask Erin? And
Sure, I'd love to. Yeah, so I really loved your presentation, Erin, on really the efficacy and utility of Vats, and I was totally blown away by your amazing surgical description, because I've never really thought about the whole dimensional and the whole, I think you called it the haptic response, whatever that is, but really amazing. So I really have a newfound respect for surgeons. But just wanted to ask, because I know there's been a lot of, you know, I think, you know, robotics sounds more sexy and just exciting. And I think a lot of people come and ask for robotic surgery, and what your take is on RATS procedure versus a VATS procedure, and how do you pick between the two?
Absolutely. I think that's such an important question. And, you know, unlike the beautiful Violet study that we have, we don't have a perfect head-to-head comparison of VATS versus RATS. And a lot of the data that's coming out is like a lot of the data I kind of presented to begin with, that it's, you know, single institutions kind of comparing VATS and RATS. Now, the interesting thing is that a lot of the data coming out shows that both methods of minimally invasive surgery can be done safely. They can be done effectively with low morbidity and good outcomes. And so that's, you know, one of the important first pieces of it. And the other interesting thing to kind of know is that there's so many iterations of both now. So we have, multiportal Vats, uniportal Vats, subxiphoid Vats, microlobectomies, which is maximizing at, 5 millimeters. So there's so many different iterations of minimally invasive surgery now. And I think one of the big drivers behind that is that, one, we really haven't found the absolutely perfect way of doing it, right? There's limitations to all. And surgeons have different comfort levels with the different ones. Now, one of the things that is a huge advantage of the robotics is that it's almost like having miniaturized versions of your hands in the chest. And so there's a huge degree of flexibility of the instruments. They have a wide variety of instruments that can be used. And so I think that's very appealing. The three-dimensional viewer makes it, I think, easier to do a higher complexity of case. And so for me, transitioning a more complex surgery like a sleeve or a complex segmentectomy was a lot easier on the RATS platform. So doing, a medial basal or segmentectomy, no problem with RATS approach, which is really nice. The big problem though with the robotics is that right now we have one company making the robots and they are crazy expensive. And even the kind of longitudinal studies looking at trying to identify the point in time at which potentially the RATS could have a cost benefit or cost savings never is really achieved in a lot of the kind of longitudinal studies. It remains more expensive than the VATS approach. No matter what you're investing in additional equipment, right? So VATS require special equipment as well, but robots certainly much more expensive. So certainly a drawback.
And my question was, given that Violet was focused on lobectomy, right? How do you integrate, the ongoing data and studies that are investigating sublobar resections compared to lobectomy?
Yeah, I think that is such an important thing to talk about. It was the 90s that also made a lot of decisions about lobectomy versus sublobar, right? Like the lung cancer study group in 95 came out after their trial looking at T1N0, M0 lung cancers and found that significant survival benefit in lobectomy versus sublobar. So really for the last 25 years, that has been the gospel. You have to do, a lobectomy for anybody who's coming in with lung cancer to achieve those really optimal oncologic survivals. Is that necessarily true? No, I think we're starting to see really good data coming out showing that a sublobar resection is appropriate in some patients. Now, I think the ongoing debate is really twofold. One, what is the threshold or size of tumor that we should be thinking about a sublobar resection? Some studies are coming out saying 1 centimeter should be the threshold. Anything bigger than that, I think everybody can agree that nodal involvement absolutely is going to have a better outcome if we do a lobectomy. There are some groups that are looking specifically at 2 centimeters. So Dr. El-Turki's data that's maturing with his CALGB trial using 2 centimeters as a cutoff. So I think size is still a little bit of a moving target. The other thing is, how should we be defining sublobar resection? Is wedge and a segmentectomy created equally? And I think the answer to that is no. We have data coming out showing that segmentectomy is superior to wedge. And I think that's for a couple of reasons, but I think one of the big ones is lymph nodes. Again, it all kind of comes back to lymph nodes. When you're doing a segmental resection, you're getting a significantly increased number of lymph nodes. You're getting, the entire drainage basin within that portion of the lung. So you're 12 through 14 lymph nodes. And then to be able to get to the blood vessels, you have to take out those station 10 and station 11 lymph nodes individually. And then, we concomitantly do aggressive mediastinal lymph node staging. When you look at the data in a lot of these groups of patients who are undergoing wedge resection, a lot of them are getting 0 lymph nodes taken out. It's just a wedge, and that's a huge problem. And so I think that really we need to be looking at segmentectomy probably more so than wedge for these patients to have a really good, recurrence-free survival and overall survival. But it's a harder surgery, right? So there's not going to be a lot of people who are willing to do it.
And I wanted to present to the panel a case and wanted your thoughts, and I might change the case in the middle of the case. So, we all have in this group of panel a large clinical practice. We have multidisciplinary group that talks together. So I have a patient who's 69 years of age who has a T1B N0, let's assume. M0, just by radiological M0. How do I think about radiation versus surgery? Which way should I go? Erin and Kim?
I think that's such a great question. And I think that's something we debate all the time. I will tell you, if that patient has a lot of comorbidities and you're going to go in and just do a wedge and take out no lymph nodes, you have done them no benefit doing a surgery. I think in that situation, you should be doing a surgery. And a patient who's really medically fit and can tolerate a good resection, either a segmentectomy or a lobectomy with an aggressive nodal staging, I think that's really critical, right? Because that's the big difference, I think, between surgery and radiation is I can actually upstage a patient if they have hiding N1 disease or N2 disease. And in those patients, they're going to be able to have the addition of a systemic therapy as well. But if you're not taking nodes, you're not providing the patient with that benefit. So I think to me, that's kind of one of the huge criteria that you need to be thinking about.
And I agree. I mean, I think, in the absence of us being able to compare them head to head, and actually that was one of the other oral presentations at this year's ASCO was the update on STARS, right? Where unfortunately STARS didn't accrue, but they went ahead and continued to prospectively accrue patients on an SBRT arm and then compare it to a prospectively collected historical comparator arm that received surgery. And those results are looking good, right? And show that SBRT is an efficacious alternative. But the one, I think, downside that Erin mentioned is that we can't tell if they're actually occult N1 or N2 or N3, right? I guess N1 or N2 we would figure out surgically, maybe N3, I guess, right? So at any rate, I think, it's a reasonable alternative for sure. A patient who either clearly isn't, a surgical candidate, that's an easy question. I think if there's also a patient who's a little more concerned, maybe they've already had multiple surgeries in the past, they technically could, survive and have pulmonary function that would be adequate for either segmentectomy or lobectomy aside. If they're really against having surgery, then I think it's obviously worth a discussion to bring them over to the radiation oncology clinic and have them understand the pros and cons, right? So, I don't think, unfortunately, we'll ever have one answer that says one is definitely better than the other, but I think multidisciplinary discussion and the best fit for the right patient is really the key here, right?
Great, thank you. Thanks, Erin. Thanks, Kim. And there's a question from the audience. Hoss, was maintenance therapy used in Checkmate 9LA?
Yeah, so, I mean, I've looked at the study design a couple of times. So maintenance chemo in the ipi-nivo arm wasn't allowed. It was just the 2 cycles of chemo, and then obviously the ipi-nivo was continued. But in the control arm, yeah, maintenance was allowed because that's what the standard of care is.
Great. Hoss, coming back to that case I just presented, suppose it turned out to be an N1 also, but you knew that N1 preemptively before any therapy. Would you ever consider neoadjuvant immunotherapy? And let's say for that patient, I did do molecular analysis and it was EGFR, ALK, MET negative as an example, all of those targetable alterations. How do you think about that? Yeah.
So this goes back to sort of institutional biases and historical precedences, right? Do we favor neoadjuvant treatment or do we favor adjuvant treatments? I remember growing up as a fellow and having all these neoadjuvant versus adjuvant studies, and the adjuvant studies would complete and neoadjuvant studies would suffer. Clearly with 816, we've seen that you can accrue to neoadjuvant trials, but which one is better and which one is going to give you that long-term, improvement in cure rates that we all want to see in early stage, I think it remains to be seen. And again, it is going to become one of these controversies whether we should do a neoadjuvant chemo IO versus adjuvant chemo IO study, and I'm not sure whether we're going to be able to do that or not. I think at this point, Ravi, I would say that with appropriate support from our surgeons, yes, I would like to do a neoadjuvant approach with chemo IO in a patient with N1 disease, pending the results of everything else. But I can sort of foresee that in the next few months, we'll have FDA approval for adjuvant IO, but not in a neoadjuvant. And therefore, it becomes a difficult question in a real clinical practice not to offer an FDA-approved regimen in favor of something that's still considered experimental. So I think the reality on the ground is that we're not going to be doing neoadjuvant unless we get FDA approval, but we will be doing adjuvant IO because that's going to be available.
Great. And suppose, Shayma, initially we thought that it was EGFR negative, but it turns out it was L858R. I'm just making that up, right? And it was T1B-N1 lesion. Would you do like a neo-ADAURA, or would you do surgical resection appropriately and then ADAURA, or how would you think about that in the EGFR setting?
So yeah, you really made the case really interesting. So of course that brings the question of how many of us are, upon biopsy, sending off your genomic analyses, right? So in the penetrance in the United States for metastatic patients, I think for non-squamous about 64%, 65% getting NGS testing. So I think that's a huge gap in and of itself. How many of us have now started testing the early stage patients? I don't know. I think the number is exceedingly small in the, in the community setting. Of course, in the academic setting, we are excited. ADAURA is exciting. We send off things, and payments and things are still a question. So yes, I think I would send off the testing in a patient like this in anticipation, and gosh, and I would probably try to do a full NGS, though no one would pay for it, but maybe I can get an EGFR test alone done somehow because there is an approval for it and the patient is positive. So based on the ADAURA data, which, we're still sort of maturing the OS, right? So it was 3 years adjuvant osimertinib on patients who had fully resected. And regardless of the stage, even the early stage 1Bs really seem to have done well, surprisingly. I think the hazard ratio is 0.5, if I remember correctly, and certainly much more striking in the node positive patients. Absolutely would want to do adjuvant OC in this patient. Now, why not neo? Well, I mean, we don't have enough data. I don't know the true stage of this patient until, Erin goes in and does her magic with whatever hands or robot hands. But I want to know that it's all out. I want to get, we can certainly talk about how do we stage these patients. There's no representation here with interventional pulmonology, but there really ought to be next time from a sense of, EBUS. Are we going to do a MEAD? What do we prefer? But I think that I would have this person go to resection, and then certainly node positive, I would also treat with chemotherapy and then follow with osimertinib. I don't think I would not treat with the chemotherapy. I think the node negative patients, we can debate all day, but.
So can I ask a question, Ravi? Maybe I can ask
as much as you'd like, please. Yeah.
I'm sorry. I'm going to turn the table and ask you a question. So we saw the Empower 010, and we've discussed incorporating that most likely. What do you do at your institutions? And Erin and Kimberley and everybody can jump in. For N2 disease, what is your take on post-op radiation? Now that we have one study saying it doesn't add much, but there's a lot of controversy as to whether that really is true or not, because older radiation oncology techniques, radiation techniques were used. So are you guys going to offer N2 for N2 patients post-op, any post-op radiation, or is that debate done as far as you're concerned?
Kim, you're the expert.
I think it's still controversial, right? I think we certainly want to see the full publication and look at exactly why there the difference in outcome. Why if one study shows N2 there's a benefit, one doesn't, right? We have to look as to the rationale why. And I think it in the end might come down to the same issues that plague 0617, as well as potentially the study that I just presented, the CALGB 30, sorry, I keep forgetting the number, 610. And that is, every case is different, right? So N2, we cover the mediastinum, we cover the hilum, and then we potentially cover the lobectomy incision as well. And so the scar as well. So the question is, where is that in each patient? Where was the positive node? How many nodes were involved? And I think if we can make the dose, the field smaller, the dose, is lower than the standard definitive dose, but it is post-op, right? So now we've lost a good chunk of lung. And so I think it's going to be a trade-off there between toxicity and potential benefit. But I think with systemic therapy improving as well, though, there may be a decreasing role for post-op radiation in general. So I think it'll be case by case, certainly not all N2, but I would definitely want to see the publication and try to glean out why, there's such a discrepancy. Old techniques aside, right? So, again, some of them might have been IMRT, some of them might have been the older 3-dimension conformal radiation. But that said, IMRT done poorly can be worse than a good 3D plan. So I think the jury's still out, but I think we're heading towards less and less.
And Erin, what about like considerations of bulky disease, skip disease, right-sided versus left-sided? Does that all matter?
Yeah, I'm so glad you brought that up. It was so funny when Kim, when you said, depends on the N2 disease, you're like speaking to my heart, because I feel like N2 disease is just such a broad category. We have microscopic disease, bulky disease, single node, multiple nodes, and then 5, 6 should be in their own category because they behave more like N1 than N2. So I think that, really you have to think about it so carefully by patient. We actually tend to do a lot of chemo radiation up front for our known N2 disease, the not surprise N2 disease. And so we're actually radiating them up to 60 gray ahead of time. And then I'm going in and resecting them as long as they haven't had progression of disease and as long as the entire burden is resectable, including an aggressive lymphadenectomy. And then we're meeting as a group to talk about adjuvant treatment. In light of the data coming out, I have seen kind of a de-escalation of, I think, PORT and a de-escalation of kind of excitement for PORT more recently, but it'll be interesting to see. I agree with you. I think, kind of getting through the nitty gritty of the data is going to be really important to really understand how this applies to each patient population.
So I think we're almost done with our time. I'd love to hear from each one of you. One thing that you think is going to be so crucial for the future that will be amazing for our patients and the curability. We'll start with Shayma. What do you think?
So what I think is going to be really, really important is the ability for community physicians as well as academic physicians to be able to test patients for these molecular markers. I think the availability of NGS, the availability of serial liquid biopsies at times of progressions and less worry about payments and just being able to freely order this. And of course, then the data back in terms of being able to carefully navigate the results. When you get 30 pages of a report and you're scratching your head going, is this a skip mutation? Is this an amplification? What's the H-score? I think we need to simplify. We need to be able to really relay that information in an executable way to oncologists who are really just inundated with data.
Great, thank you, Shayma. Erin?
I think, two big things. One, making sure that we have a standard, reproducible, high quality surgery that's being provided to all of our patients. I think there has to be better standardization of especially nodal resection. And I think the other thing too is gone are the days that surgery ever should be thought of as a treatment alone. I think we're seeing, all of the systemic therapies, targeted therapies moving into earlier and earlier stages. And so I think that just really kind of underscores that lung cancer demands a multidisciplinary approach, period, across all stages.
Great. Thank you, Erin. Kim?
I'm excited that, with immunotherapy really revolutionizing the treatment of lung cancer, that radiation, it seems to be playing an important role in potentially augmenting that response and studying, whether it's our conventional radiation versus SBRT, our high dose, it's a short course radiation, using it in different settings before or after immunotherapy. It seems, with Pacific that there's this really wonderful response, after radiation to give durvalumab, and it's just, I think the world is our oyster now in trying to figure out how we can help you medical oncologists with your therapies, and our role in as a local treatment may actually broaden to being even assisting the systemic options as well.
Thank you, Kim. Hoss?
I mean, not to be a party pooper or anything, but I don't quite think that the world is our oyster quite yet. I think we still have some work to do, but I foresee two potential things. One is that I think biomarkers are going to lead the way. I think we are going to get to a place where we can actually do real-time measurements of tumor microenvironment, whether it's tissue or blood, and I'm hoping it's more blood than tissue. We are going to get to a place where we can actually deliver a very personalized level of care. I think the crop of new checkpoint inhibitors and immunotherapy-based regimens that are coming out are very, very exciting. And I'm really hopeful that some of these will be showing us significant, not just incremental improvement, but it is going to take a lot of time and effort and a lot of expenditure of energy on biomarker identification sort of to lead the way. And then second, and Erin isn't going to like that, I think we're going to get to a place where our surgery is so minimally invasive, we won't even need surgeons anymore.
You may not be wrong. I mean, all the crazy things coming down the pipelines with endobronchial ablations, injections. I mean, there's incredible options coming down the pipelines. And I think it's going to dramatically change how we take care of patients.
She says that on the call, but next time she sees me, she's going to punch me.
Great, Hoss. Thank you for a great discussion. And for me, it's really crucial for us to invest in screening and the screening tools, the technologies, and COVID really has come to hurt us. And that's quite devastating for all of us, right? In terms of our screening and not enough patients and then diagnosing early stage disease. So we have to really invest. And can we also build in, let's say, cell-free DNA in terms of screening or other platforms? That's going to be important. But at the end of the day, the biggest thing that I'm looking forward to is much more investment in research so we can truly cure lung cancer. I think it's time that we open up the floodgates for research into lung cancer, and it's really an important issue for all of us. So I wanted to thank each and every one of you for presenting beautiful data sets, as well as great discussion. And I also want to thank Dalen Miller for helping us getting organized, and also all the sponsors. So thank you so much, and everyone have a great day, have a great weekend as well. Thank you.
Thanks, everyone.
Thank you.
Bye.
Thank you.